when you are considering starting a patient on a PARP inhibitor or starting a patient on a PARP inhibitor, really careful patient counseling and setting accurate expectations for your patient is just key. It's 100% of the battle. Because most of the time, our patients have never seen an oral agent. And most of the time, they're really excited to try an oral agent because they're tired of infusions. So they're expecting an oral agent to sort of be like taking a Tylenol. And so if we give them a prescription and let them go off with that expectation, they're going to all discontinue PARP inhibitors because it's certainly not like taking a Tylenol. So you really have to set expectations well. I really talk about first just sort of, depending on which PARP I'm going to use, how it's dosed. If it's dosed twice daily with olaparib and rucaparib, if it's dosed once daily with niraparib, I talk about the time of day. Like with niraparib, I talk about taking it at night. And I usually pre-medicate early on with an anti-nausea medicine so they can just sort of sleep through any nausea, and that kind of helps ameliorate that toxicity. So I talk about timing. I talk about sort of what to expect. So nausea, low grade, but feeling queasy every day isn't great. So how do you overcome that? Fatigue. The fatigue is real and it feels different to patients. They're not used to feeling that kind of low grade meh every day. It's very different than infusional chemo. So they may think they understand fatigue, but then it feels different to them and they get anxious about that. So talking about fatigue and then ways to overcome fatigue, staying active. There's, I'm from Oklahoma, so there's kind of herbal teas and things that patients like to try. It's not counteractive with the PARP inhibitors, so I'm fine with that. It gives them something to try, and often it makes them feel better and empowered that they're doing something. So just make sure you know what your patients are taking. So I really go through kind of the low-grade, most common toxicities, which are nausea, fatigue. I do talk about dyspepsia, and then diarrhea versus constipation, and then how you can overcome those. I send patients home with a prescription for an anti-nausea medication. Not everybody does, and that's fine. You can choose to sort of let patients see how they feel and then quick call and they get a rapid response. I tend to start it for 1 to 2 months, and then once we're fine and rolling and people feel comfortable with the dose that they're on, we try and wean that off because no one wants to be on Zofran for 2 years. So I tend to start it so that we don't get into that cycle of nausea and then pull it off. But that's not like something you must do. It's just an idea. We've done a lot of training with our office staff so that they feel comfortable assessing toxicities for patients on PARP inhibitors. We have clinical pharmacists that also take those calls, so we're very fortunate. So they can help with dose modifications, even if I'm not there. Like today, I'm not there, but if one of my patients calls, she's going to get completely appropriate feedback on what her symptoms are. And if someone feels like she needs to hold, they're going to tell her to hold. So really, education of the office staff is key, because initially these patients will call with a lot of questions and concerns about the side effects, and you have to be able to provide reassurances and action plans for sort of things that need an action plan, or they're going to come off because they don't feel great on it. So I think setting expectation and having a plan for those key side effects is really key. I do think that as a part of counseling for PARP inhibitors, we have to talk about the risk of AML and MDS because it's sort of all over the concerns of PARPs, and it is real, but it's low. It's 1 to 2% across all programs. If you're in that 1 to 2%, that really stinks though, because it's not a fixable problem and it tends to be often a terminal event for our patients. It's likely that there are risk factors that set that patient up for developing AML or MDS that we haven't been able to identify yet, although we've tried. AML, MDS with PARP inhibitors is an early event. We see it like between 1 and 2 years. Usually it's not an event from 7 years of PARP inhibitors. So there's something that patients are at risk for that we tip them with the PARP. But it is a low risk, and so I think patients need to know that. They're owed that. We talk about the 1% risk of bowel perforation with bevacizumab, so we better talk about the 2% risk of AML, MDS. So I don't harp on that, but I do make sure patients have heard it. But mainly I talk about the low-grade side effects and mitigation strategies. Adherence to PARP inhibitors, is key. That if you're not taking them, they don't work. And we know from the breast cancer literature, even with hormonal agents, that patients don't always take their medications. They stop when they're on vacation. They do all sorts of things that we don't know about. Although now we're studying it, so we're figuring it out. So I think, if patients aren't taking the medicines, they're not helping. So I think it all comes back to sort of setting expectations appropriately with patients, and being very responsive when they have concerns, and reassuring them about the low-grade sorts of side effects. For example, several of the PARP inhibitors have low-grade dyspnea as a side effect. It's very low-grade, but it's real. Patients feel a little dyspneic. If they know it's a side effect of the drug and not like, oh, my pleural effusion is back or my cancer's coming back, they're usually fine with that. They're like, oh, I can live with this as long as I know it's not my cancer. Or on niraparib, you can get some low-grade tachycardia. That is not, patients feel it and we can treat it. But if they are worried that something bad is happening to their heart, or they're having a pulmonary embolus, or the other terrible things that happen to our patients, they're likely to get anxious enough to come off. So it comes down to setting expectations with patients and really responding when they call to their complaints and providing quite a bit of workup. If you're not sure if it's medicine related or disease related, sometimes it is, their disease is coming back and we have to respond to that. And providing reassurance when you realize it's not, so that they can stay on. If you look at the studies, it's again very consistent across the 3 studies. Patients do not discontinue maintenance PARP inhibitors due to adverse events very frequently. It's like 11 to 13%, which is pretty low. Compared to bevacizumab maintenance, that discontinuation rate's over 20%. And we think bevacizumab is a very well-tolerated drug, and it is. It's a great drug. But patients discontinue it because of the bone pain and other sorts of things 20% of the time. So this is like half. So at least the study population is on, and they maintain for as long as they need to. You'll probably see a little higher as it rolls out into general population, but it's not a drug that patients are just telling us what they're, sometimes they vote with their feet when they don't like something. We're not seeing that with PARP inhibitors. So I think that providers are likely doing a very good job doing what I've talked about, because we don't see high rates of discontinuation.